I'm truly honored to be a facilitator for this session. My name is Sujira Claudine Mimi, and I work as the Manager for Academic Partnerships and the Paul Farmer Collaborative at the University of Global Health Equity. Honorable Minister, distinguished educators, ladies and gentlemen, all protocols observed, welcome to Kigali. We are delighted to have you here. For those that are in the room and those that are joining us on the live stream around the world. Good morning, Mwaramutse, bonjour. Good morning. Can we get the energy in the room? I would love to provide more context on why we are here, but I think that the next speaker would be better placed to give us more insights. Ladies and gentlemen, it's a pleasure to invite Professor Abebe Bekele, the chair of the conference organizing committee. He's also the Deputy Vice Chancellor of Academics and Research Affairs and is the Dean of Medical Education at the University of Global Health Equity. Please join me as we welcome Dr. Bekele.
Thank you very much, Mimi. Good morning, colleagues, friends, distinguished guests. On the behalf of the organizing committee, the International Steering Committee, and the entire UGHE, it's my absolute pleasure to welcome you all to the first edition of this landmark event, Advancing Medical Education in Africa, a collaborative leadership conference hosted by the Ministry of Health of Rwanda and the University of Global Health Equity, UGHE. We are deeply honored to be joined this morning by our guest of honor, the Honorable Minister of Health of Rwanda, Honorable Dr. Sabin Nsanzimana. Thank you, Dr. Nsanzimana, for your unwavering support to this conference, to UGHE and health education and innovations across the continent. Today is more than just a conference. This is a beginning of what we hope will become an annual space, a vibrant academic and scientific forum where medical educators, students, academic leaders, researchers, policymakers, and partners from all across Africa and beyond come together. A space for shared learning, partnership formation, for critical reflection, and for imagining together what the future of medical education in Africa should look like. Our inspirations come from similar remarkable global experiences, from the AME conference in Europe, the AAMC in North America, and other platforms that have transformed how health professionals are trained globally. Africa deserves the same space, shaped by its own needs, its own voice, and its own aspirations. Our first objective, therefore, is to establish this annual gathering as home for that ongoing dialogue. Our second objective is just as bold and necessary: the formal launch of the Consortium of Medical Schools Africa COMS-A. This will be the continent's first truly inclusive platform of medical schools, designed not only to unify but amplify the work we are all doing in education, research, social accountability, and health system strengthening. We hope, standing together, can contribute better to the callings of the healthcare development and research in our continent. And today, I'm deeply proud to say that this vision is already taking root. In this room, we have 111 deans and leaders of medical schools present here in person, and over 10 more deans joining us virtually. Alongside them, we have 17 provosts, 2 deputy vice chancellors, 6 directors and executive directors, and 5 contributors, major contributors in education, gathered in this room. We are over 600 participants strong, and we will witness 54 poster presentations, 30 scientific paper presentations, several expert panel discussions, a very interactive and visual learning session, and so forth. We'll also celebrate excellence with awards for best paper and best posters, and we're honored to feature keynote remarks from globally renowned voices in education and leaders in global health. Stay tuned, you won't want to miss these. Leaders of the World Federation of Medical Education, WFME, World Medical Association, WMA, the WHO Afro, the Association of Medical Councils of Africa, AfriHealth, FAMER, the American Association of Medical Council, the Association of Physician Leaders of America, the Gates Foundation, and other globally renowned medical education stakeholders are also amongst us. This year's theme, Innovations in Medical Education Practices, calls on us to imagine boldly. Over the next 2 days, we will explore digital transformations in medical education, simulation-based education, global health and social medicine, leadership, research and innovation, and the very crucial role of what humanities and social medicines have in building compassionate, well-rounded health professionals. Of course, it's not all lectures and learning. We hope you will join us for our welcome reception tonight, a chance to relax, dance, and enjoy some wine. Purely for research purposes, of course. We'll also test if our simulation training extends to the dance floor. None of these would be possible without the support of our amazing partners. We sincerely thank the Paul Farmer Collaborative, an academic partnership between UGHA and Harvard Medical School, the Gates Foundation, Novartis, Creighton University, the Arupe program, and all our generous partners and collaborators for their support in the organization of this conference. A special thank you to the International Steering Committee. At this juncture, I would kindly ask members of this committee to please stand up to get recognized. The International Steering Committee. Our dedicated local organizing committee, the tireless team at UGHE, and I mean the entire UGHE apparatus, led by Ms. Claudine Mimi and Dr. Victor Miti. Please stand to get recognized. And our event organizing firm we are working with. Ladies and gentlemen, this is your space, your platform, your moment. We're just trying to create the opportunity for us to collaborate. We invite you to engage fully, connect boldly, ask questions, and build relationships that will shape the future of medical education in Africa for decades to come. Please allow me to invoke His Excellency President Kagame before I conclude. He said, Africa's story has been written by others. We need to own our problems and solutions and write ours today. I guess that's why we are here today. Thank you very much, everyone, and welcome to Uganda.
Thank you, Professor Bekele. Another warm hands of applause to him. Next, I am pleased to introduce one of the most passionate educators I know, Professor Phil Cotton, the Vice Chancellor of the University of Global Health Equity. Please welcome him on stage.
Can you see it? Can you see it? Because you see, When the University of Global Health Equity was envisioned, people thought Paul Farmer some people thought he was a saint, some people thought he was a bit of a madman, but he said, maybe he's all of those things and more, but he wanted to create a university, create a medical school that would train the next generation of people who would transform the health sector, who would transform the lives of people who present themselves sometimes as patients within the health sector, that they would begin to transform health policy in the continent of Africa. But in order for young people in the university or any university to be transformed, we need to be transformed. We need to be prepared to be transformed. Ladies and gentlemen, just stop for a moment and look around this glorious room at the people sitting behind you. Because all of us are going to be transformed in the next 2 days. Otherwise, this conference is just like any other conference. I want you to feel the possibility of being transformed. And transformers can either crank up the energy or wind down the energy. You have made a promise, and the promise that you made, you may not have made it explicitly, but the promise you made when you took on your posts, either as medical doctors or educators, was to make a difference, to change the world, to crank up the energy. Can you hear it? There can be miracles if you believe. Can you hear it? There can be miracles if you believe. You see, the starting point for everything we do is belief. And it only needs the belief of the people in this room to create a miracle. And that miracle is to transform the lives of people in Africa through the work that we do in health. That's the miracle that can take place in this place. Because of the promise that you made, because of the purpose that you have, and because of the possibility that you believe in. Anything, but anything is possible. And as healthcare workers, as medical educators, we have an unending belief in the possibility of change. I heard something of the panel before. Isn't it strange how you still walk into a healthcare setting these days and the doctor is sitting behind this magnificent desk, piled high with all of the artifacts of healthcare, all of the things that demonstrate their importance, and none of the things that demonstrate the true humility of healthcare workers. Ladies and gentlemen, we can do a very simple maneuver, and that is to shift our desks to the side of our consulting rooms and to sit with the people who matter most. There must be nothing that stands in the way of us serving the people that matter the most. You know, nothing at all. Nothing at all. It doesn't matter. Just move things. Just create space so that you can do the things that matter most. Cause disruption, but get to the people that matter most and the people who will change this world and transform this continent and make a difference to the lives of the people that we were called to serve. That That, ladies and gentlemen, is the only reason that this university was set up And it's the only reason that this university put its full backing behind this conference. You, ladies and gentlemen, in the next 2 days are going to transform the world of medical education, not just in Africa, but beyond. You, ladies and gentlemen, are going to transform the world of medical education, not just in this continent, but beyond. And you, ladies and gentlemen, not to leave you out, are going to transform the world of medical education in this continent and beyond. So I invite you to be transformed. I invite you to change this world through belief, through purpose, through promise, and through possibility. Thank you.
Thank you, Professor Cotton. Due to conflicting commitments, Dr. Chikwe Eyakweazu was not able to join us in person. Dr. Chikwe Eyakweazu is the acting regional director of the World Health Organization Africa. But he put his remarks in a video. Let's start the video.
Dr. Jim King, Chancellor of the University of Global Health Equity, Professor Philip Cotton, Vice Chancellor, honored guests, esteemed deans, faculty and students, friends and partners in global health. It's a great honor to join you virtually today in Kigali, a city that symbolizes resilience and transformation. Thank you to the University of Global Health Equity for convening this important conference on the future of medical education in Africa. Our continent stands at a critical juncture. We carry 25% of the global burden of disease, yet have only 3% of the world's health workforce. This imbalance limits our ability to deliver equitable, quality care to all our communities. We know this story all too well. But today is not about statistics, it's about action. This gathering is a call to collaborative leadership. It's a platform to rethink how we educate and empower the next generation of African health professionals. The World Health Organization estimates that by 2030, Africa will need 6 million additional health workers. But the issue isn't just the numbers. It's also about ensuring a workforce that is well-trained, competent, and equitably distributed. WHO is fully engaged in this mission. Last year, we launched the Africa Health Workforce Investment Charter. This is a bold, regionally owned commitment to securing political, technical, and financial investments in our health workforce. The Charter provides a roadmap for transforming health workforce planning, education, employment, and retention across the continent. It recognizes that medical education is foundational to the strength of our health systems. This is why this conference matters so much. By bringing together Africa's medical educators, health leaders, policymakers, and partners, we can co-create the sustainable solutions that we need. The proposed Africa-wide consortium of medical schools will be a historic step. Unlocking the collective power of our continent, it can drive resource sharing, curriculum and accreditation alignment, and innovation through African-led research and knowledge exchange. Importantly, it signals a shift from relying on external models to embracing homegrown excellence. As His Excellency President Paul Kagame has so rightly said, Africa's problems are best solved by Africans. Yes, the challenges are complex, from infrastructure gaps and faculty shortages to limited technology and the persistent brain drain. But the solutions are within reach if we act with unity and urgency. We must invest in digital learning platforms to expand access across the continent, We must harness simulation and artificial intelligence to enhance and not replace human-centered education. We must embed social medicine and community engagement into medical training. This will ensure that we produce not only skilled clinicians, but compassionate change makers. Above all, we must center equity in everything we do. Colleagues, the World Health Organization stands with you. We are not just observers in this journey, we are partners fully committed to implementing the Africa Health Workforce Investment Charter alongside African institutions, governments, and communities. This is key to ensuring every country has the skilled, motivated, and supported workforce it needs. Together, we can train, retain, and empower the health professionals Africa deserves. I commend you for taking this bold step, and I look forward to the lasting impact of this consortium and the other proposed initiatives. Thank you all very much.
To welcome Dr. Pauline Basinga, the Africa Director of the Gates Foundation, whose work has made meaningful impact on the healthcare across Africa. Please join me in welcoming him to give his remarks.
Thank you very much, Mimi. When I was at medical school, I created a theater group. And I thought that I would be a really great speaker. But today, I'm wondering why Professor Phil Cotto chose me to come and do this. Following you and following Dr. Chikwe is going to be very, very challenging. But I'll try my best. I am really, really very thrilled to be here. And it's quite a privilege to be here. As you heard from Dr. Abebe, Professor Abebe, there are more than 110 deans of medical schools here, more joining online as well, and other medical educators here. This is an amazing crew that are going to actually change and transform the life of many in Africa. And it's truly an honor to be among all of you to provide this speech today. Having spent some time in academia, I don't know if they will be able to put my slides on. I've been doing my best to try to follow what is happening at the university across Africa. So I'm now based in Nairobi. I lead the Gate Foundation office in Africa. We have 5 offices in South Africa, Nigeria, Ethiopia, Senegal, and Kenya. But then when I go, every place I go, because I came from academia and then moved to philanthropy, been working a lot with ministries of health, I try to find, people who are transforming lives. And I now live in Nairobi. And one day I was driving around Nairobi, and something quite remarkable happened. Traffic across the city was standstill. It might sound like unusual for people who know Nairobi because most of the time we spend a lot of time on traffic. But then I realized that one thing was happening. Professor Moses Obimbo has organized a Run for Her march. How many have heard about Run for Her march for people who live in Nairobi? Quite impressive march that rallying thousands to raise awareness about postpartum hemorrhage or PPH. He made the entire city pause, not for a crisis, but on a controversial, but really trying to really save many women's lives. Professor Obimbo's work with the 2024 World Postpartum Hemorrhage Initiative is a powerful example of how academia can drive real-world impact, how the leaders in this room can turn innovation into solutions that reach communities. Just imagine when Professor Obimbo shows up in a classroom, the ripple effect he has in his own students in the classroom, because he's not only teaching, but he's also showing them how academics can actually do 3 things. The thing that you do well. You teach, you do research, but also you do community services. Because you are trusted, you can actually transform life in a very, very big way. Today, I'm going to show a little bit of, talk about 3 innovations that has been quite instrumental in the life of many. So I'll talk about 3 innovations, but before, I wanted just to show my picture when I was at the medical school here. This is me in 1995. I'm from Rwanda, grew up in exile in the DRC, came back in 1994 at the end of the genocide, and the government here was determined to actually reopen the School of Medicine very, very quickly. In 1995, some of my professors are in the room. In March 1995, they actually opened the medical school, and it was crowded. A campus that was meant for 1,500 people, we were more than 5,000. Many medical doctors came, helped us. We were doing our best to try to solve medical problems with the tools that we had at that time. There was no internet. I don't know if you remember. And when we were medical doctors, you used to have those printed, compendium of medical, of medicine in our pocket. And you'll have to go through pages to try to find an information that was printed in Belgium or the US or Europe many, many months or many, many years ago, shipped here without any idea about the last evidence that was published, right? But today, it's completely different because students have actually information in their fingerprint. And today, in the side there, you'll see my dear friend and colleague, Dr. Martin Nyundo, who is one of the renowned surgeons here, just published. We're in a WhatsApp group of all medical doctors. We've worked together for a long, long time. He just published his PhD, talking about how to improve minimally invasive surgery in Rwanda. Just see how very, very far, we've came as a community. So it's a reminder that we can actually be really optimistic and try to see what is happening. So I was in Tanzania recently, where I visited the Muhimbili Medical Hospital, an amazing hospital, where state-of-the-art facilities have been built by the government, and they've, really teaching students in a very, very impressive way, and they're really trying to improve quality of education, healthcare delivery, and many, many more Tanzanian and East African are, having care there, and we're really reducing a number of people who are going away. The latest information, that students have today is it has improved in a very big way. I'm a big fan of AI, but at the same time, as Phil Cotton said, it's impressive, it's important that we continue to remember the interaction between doctors and patients. We just need to use the technology to give us the information that we need, but there is no technology that will actually replace that interaction between, doctors and patients. People often talk about blue sky thinking when they describe innovation, but I see it quite differently. To me, if we live, the boundary that we live in every day, it's trying to really find grounded solution in the reality that we have and try to work with real people to try to solve for the real, problems. But the kind of innovation that truly minds, the kind that come from being stuck, being frustrated with our, routine and bureaucracy and challenge in our facilities, etc., that is the kind of powerful innovation when we try to find innovation that unlock those issues. It's what makes things more equal, more accessible, and truly transformative. So today, let me show you 3 innovations. Number 1, I'll talk about the incredible potential of AI revolution. What AI is grabbing press headline in a very, very big way this day. Number 2, I'll talk about mobility and portability around, how nanotechnologies and the proliferation of mobile technologies and advancement in robotics are enabling new era of healthcare learning, upskilling, and also service delivery. And the third, I'll try to give you some example of big data and how government and partnership are actually changing how we think, how we teach, and how we do research. And then I have one small surprise for you that I'll be talking about. It will be my 4th one. So let me go to the first one. I think it will be quite hard in an innovation conference in 2025 if I didn't talk about the transformative impact of AI that it's really having in our technology every day. I think we're still discovering the full potential of AI, and learning how to use it responsively and wisely will be critical. But I think we also need to really work with entrepreneurs, including many in the room, to really try to turn the power of AI into solving problems that we have today. It will really provide a remarkable result. For instance, if you imagine a nurse in a rural clinic in South Africa with limited access to specialists, she can now use AI to analyze symptoms and medical histories, improving accuracy of her diagnosis and treatment suggestions. You know, Dr. Chikwe just said now that we have a lack of number of medical professionals across Africa. You all train the top-notch medical specialists across Africa. And there's always been this tendency of not giving up because you care so much about the quality of care, your patient, etc. But at the same time, we just need to see where the world is going and try to democratize knowledge, because now, as you know, I left, I don't know if Professor Baribgira is in the room. When I finished my medical school, I wanted to be a pediatrician. Back in 2000, I went to the pediatric department. I wanted to be a pediatrician, but I couldn't finish. I moved to public health. I did my master's and PhD in public health and then evolved in public health. But today, I can act using technology like most of you. So I tried it even last week before coming to talk to you to make sure that I'll be correct if I say this. The power of AI today, as you imagine, in the past, we used to have one professor. In our pediatric department, we were all rushing toward Professor Baribgira, who came from Burundi, from France. He had huge experience in pediatrics. He had his own experience, a number of cases that he has seen in the past, but at the same time, he was an avid reader. He was reading a lot. But it was only him and other pediatric specialists there. But today, you can actually access many more Professor Baribgira at a time, including some of the instant publication in PubMed today. Because if you set up a chatbot, which is very smart, you say, act as a specialist in pediatric working in rural Africa. Here is a case that is coming to me with this case, etc. Give me the next steps. What I don't want us to teach our students is to actually say to them, if you only do that, you've got it. Not at all. You have to go through the practical medicine. You need to know your physiology. You need to know your anatomy. There is no shortcut on that one. But when you know that, and you know how AI is structured, how they've pulled all the data, etc., and you know how to query it, the transforming power of information in your fingerprint is critical. At the same time, we can actually move that knowledge down to the layer of health workers, down that are closer to the people, so that nurses are not waiting. I worked a lot in public health. You know, what we used to do in the past is when you look at any public health program, we used to print a lot of guidelines that we sent to the district, and then the district sent to the facilities. You remember? You've done some consultancy to create the decision steps for any disease, right? And changing that is very difficult because the printing, the transforming, there are a lot of markets there. Many people get some funding based on that. But today we can actually leapfrog and try really to get information down. So back to my nurse in South Africa, we can actually allow her to have a lot of information there. So that's why this conference matters so much, because it gives us the opportunity to reflect on how AI can help us reimagine this and strengthening medical education across Africa, equipping the next generation of health professionals with the tool they need to actually lead and transform our medical education. But to do this well, we must work hand in hand with our colleagues in the tech and innovation communities, ensuring that the latest advancement of AI are embedded in our curriculum so that we have really good, updated curriculum now. The COVID pandemic actually led to an unprecedented investment in capacity building for telemedicine. Remember when we were all stuck at home, many people came up with a lot of innovation how to reach people without going, to them. Through initiatives like I3, the Gates Foundation supported dozens of African innovators using remote mechanisms to expand education, consultation, and treatment to deliver telemedicine appointments for busy families, remote delivery prescription to elderly patients, and remote training for AI-enabled ultrasound technicians. The ramifications are quite big. If you look at, how today a surgeon who is based in Johannesburg can actually operate a woman who's located 2,000 miles away with robotics trying to really, mimic precisely the movement of his highly trained fingers. Today, a consulting dermatologist can actually view not only a digital picture, but also you can actually send to the dermatologist a 3D view of a dermatologic lesion, and then they will sitting in one capital city, actually provide a lot of information to the patient who's actually seeing the provider who's actually seeing the patient. Just as that dermatologist and surgeon can use new visualization and robotic to serve patients, new simulation actually can transform how we teach students. Indeed, tomorrow students can practice any scenario, any eventuality before they even meet a patient. You remember when you were all being trained, you used to think about what are the cases that I've seen, right? But today you can actually see more of those cases. So we must really adapt our education processes to teach hybrid skills for future hybrid work, recognizing the reality of both remote learning and remote services provision for the future of healthcare, and helping our students to bridge that gap. It's not just the pandemic that disrupts schooling, and the universities in this room have actually the power to think bigger about these new technologies and consider how they can mutually enable distance learning, students, and sister institutions to enable to continue their studies. I think one of the other things that I wanted to mention here is as we incorporate this new technology into our life, we create data at scale that can, that we've never seen before. Like the number of data that is out there because of the new technology is huge. But our capacity to assess that data is going to grow and grow until it will surpass what every computer can actually manage. And with this incredible new computing power, access to huge data sets will become access of the future. And the challenge that we have on access to data is that Africa has always been actually behind. As you know, Google started creating the access to cloud many, many years ago. It only happened in Africa 10 years after it was available in Africa. So we actually need, as Africa now, to really advocate so that technology comes to Africa faster, so that we adopt those technology faster and then help to move very, very fast. And that is the responsibility of our government. It's a lot of responsibility for them across Africa, and they have actually to take the lead in organizing this. I'll be actually returning to Kigali next week. The government of Rwanda is organizing the AI conference, Africa AI conference, which will be discussing also the potential of computing, how to help African countries actually improve their computing power. Now, let me show you another example of big innovation that has been put in place by Africa CDC. It's called the Africa Pathogen Genomic, PGI. It was set up by Africa CDC and backed by leading global technology companies and health organizations, including the Gates Foundation, just during the pandemic. Nearly, as you know, nearly 140 diseases outbreak are detected in Africa annually. And genomic sequencing can provide essential scientific evidence needed for health systems to better prevent, identify, and track this outbreak. I think we're in Rwanda now, and Honorable Minister Sabin is in the room. You heard the story of Rwanda controlling the Marburg outbreak in a very, very significant way. This was the power of research, delivery. The medical doctors that were in the forefront came together to actually drive that. So I think we need to continue connecting universities to to the Ministry of Health in a big way. The next one I'm going to talk about is the Africa Innovation of the Future. And that brings us to innovation, which is here in this room. I said that I'll talk about the three things: AI, remote, and then the big data. But the other innovation is actually the University of Global Health and Equity. The fact that we have a university located in rural Rwanda, being able to bring all of you here together to try really to drive people to work together, it's really transformational. We're very proud to be associated with this engagement. Thank you very much, Phil Coton, and the leadership of UGHE. And it shows that actually good science, better students can actually be produced here in Africa and really drive the transformation of the work. I remember when UGHE graduated his first class, His Excellency President Kagame described it as the subversive idea that world-class health education could be delivered in Africa. Now, UGHE itself is an innovation, and that progression will continue to be quite transformative. So today, I wanted to make sure that we see the fruit of that progress, the inspiration effort of deans in this room, whose efforts and collective action are invaluable in solving the challenge facing African medical education and medical practice in the years to come. I'm proud that the foundation chose to support every one of the innovations that I talked about today, including UGHE. And in my own remark at that time, you remember I said that tools and technology to improve health are only effective and efficient as those people that are empowered to actually deliver them. We really need to continue to put people in the first. This is why having you in the room, having your faculties back home, your students, really work all together to improve the work of, the life of our people on the continent. And as you know, progress doesn't happen to its own. Too often, promising innovation remains stuck in the pilot stage. We do have a lot of pilots in Africa, especially in the innovation. Don't continue to just pile in that. We really need to make sure that we get the full potential of those pilots. It's only when they are included into the national programs and they are scaled at, they're piloted at scale and sustained. That's what will really help. This is how you come in now. Innovation requires more than creativity. It demands commitment. It needs leaders who understand the reality on the ground and who are willing to work across systems to drive change. This is why, it's critical for academics not only to teach and publish, but also to engage actively with government and to serve on technical working groups. Like myself, I was, sharing with Honorable Minister Sabin, I learned my medical and public health not from my publication on my etc. I learned from spending hours in the Ministry of Health at the district level. We actually need to teach our medical students to even most medical students actually engage with the district when they're appointed. And the first reaction, they're frustrated because they actually don't know the reality. So you actually need to play that role as dean to train the students that are willing to even understand. And most of the time, our leaders appoint ministers of health from your faculties. And some of the ministers of health have never even engaged with the government, etc. So it's really important for us to move forward. So deans, this is your moment. And I'll close by saying that I started by talking about Professor Obimbo from Kenya, who is a Kenyan son. But across your institutions, there are equally brilliant minds, researchers and lecturers and clinicians, ready to lead. Give them the opportunity. Let his story remind us that our universities are rich with talent. Seek them out, support them, and help them move. Because most of the time, I've never been a dean of School of Medicine, but I was a deputy director. I know deans, you are very important. Sometimes people can't get to you. You can open doors, or you can actually close doors. They are talented researchers there in your faculties. They're just waiting for the dean to approve like a grant that they're applying. Sometimes when we go and we know exactly who are doing the work, but the challenge probably will be the bureaucracy. Try to open, unleash their potential so that we can have more and more Professor Obimbo. I'll close by showing you this slide because I really like us to actually build from things that exist already. You know, as I was looking at you in the room, like looking at people who are attending the session, I was not Googling you, but going through this website, which is Africa Research Connect, which is managed by the African Population Health Research Center, APHRC, Nairobi. So it's an initiative that the foundation funded because as an African, when I joined the Gate Foundation, I was outraged by how many fewer African researchers were getting grants at the Gate Foundation because the Gate Foundation knew people from Harvard and MIT and Duke and Washington, etc. Then we started the process of actually creating a database that will list all African universities and list African researchers with their publication, etc. Go to the website, check if you are there. If you are not, reach out to them so that they can ask. See if your staff are there because we will be, sharing these links, across so that many donors and funders and opportunities can actually find the Professor Obimbo in your school. Thank you very much for having me. I'm so thrilled to be here, and I wish you all the best and a great meeting. Thank you.
Thank you, Dr. Basinga. Now, it is my distinct honor to welcome our guest of honor, an inspiring leader in medical education space, Honorable Dr. Sabin Sanzimana, the Minister of Health of Rwanda, to deliver his official opening remarks.
Thank you. Good morning. So I had a speech, 3 pages, that my team had prepared. But everything I had to read has been already addressed by previous speakers, especially some of my teachers, actually. Dr. Paulin, we're together at university, but was ahead. Phil Cotton led the University of Rwanda, and he was my boss at RBC as chair of the board. Professor Abebe has mentioned 50% of what I had, and Chikwe from a distance. So basically what I'm going to do is to reflect on everything that has been mentioned so far. So, and I happen to be in between the beneficiary side or the implementation side, but also the academia, because sometimes I teach, sometimes I follow on the implementation. So I'll be very brief, maybe mentioning 3 points. Number 1 is what have we done best? Second, what can we do better? And third, what are the requests from the community, from the people we are serving? So we've done so well as educators, as researchers, and leaders, politicians, to make sure health, education is prioritized at some extent. That we have new medical schools, we have departments, we have new fellowship programs. But this is very recent, and I don't think it's even expanding at the level we want it to happen. At least we've made a step. On the other side, the demand and the needs have increased significantly. The people are going to hospitals, people need doctors, they're even asking for specialties and subspecialties. When we finished medical school, we didn't know much about fellowships and specialties and subspecialties. Even in my village, the nurse head of a health center was called a doctor. And she was operating and even doing some complex surgeries, because that's the only most educated person who was handling all the needs. She had no other options. But today, the demand has gone up much more than then. And when the demand is there, we have to respond, and we have to connect the demand to the production, education. So that is at least what we know. Medical education is important. There's no debate about it. The disease burden has increased. There's no debate about it. It's actually changing every single day. We've moved from malaria, HIV, TB, diarrhea, diseases are the main killers. Now we are into non-communicable diseases, cancer, cardiac surgery, and renal diseases, kidney transplants. These are the new things that we're seeing on this continent. The shift is not, it's actually recent, maybe 10 years ago. But it's not just the shift of needs, it's probably the result of living longer, but also of lifestyle, of the exposures that have changed. People have been asking, why do we see more cancer cases and heart diseases than before? But the answer is because before we didn't have time to see these diseases happening. People were dying at 40s, at 50s. Now people are living up to 70s, 80s, 90s. So you have a chance to see those diseases. It's not that they were not there. It's because we couldn't see that happening. People are dying from other causes. So we've managed that. That's another thing we've done so well. In public health, in diagnostics, in tournaments, pediatrics, those were the success of the past. Now, we are looking at a new chapter. Both infectious disease, non-communicable diseases, diseases of wellness, diseases of living longer, and we must shift our strategies, both at the implementation and also at the education side. It's a crossroad. So how do we manage both? Because it's like a double burden for us. And how do we work closer together to make this happen? Let's be honest to ourselves. We've worked in silos in some cases. Dr. Paulin has mentioned it, where university, academia, and teaching research were somewhere disconnected from implementation. Are we better now? I don't think so. Not yet. We are close. What is missing? Who should be moving closer to each other? We have all to move. We have to move towards a common goal. Because at the end of the day, we are serving the same people, same communities. We're serving ourselves. So what have we done well? It's clear. But there's a lot we have to do better. This is what I want to address. Probably I'll be very direct, reflecting from across, but also from what has been said before. We've had cases, and I'll be using real examples, some of the universities where you could see clinical doctors and academic doctors. For about maybe 5-10 years ago, you would see a pediatrician who is academic and then a pediatrician who is clinical. These are real cases. The academician, pediatrician will go and teach students in a university, follow them at the hospital, go back at university with the students, and leave the hospital with pediatrician, clinician, and sometimes with a few students there. And one is paid by the university, and another one is paid by the hospital. This is a situation we lived in for about 5 years. And we sat together and said, why do we have academic doctor, pediatrician, and a clinical pediatrician teaching the same students? They're teaching in the same hospital. Then the university is just there for procedures and signing documents and approving degrees at the end. Why don't we teach in the hospital, make the hospital itself as part of the university, as a teaching site? So that is the most recent changes we agreed with the University of Rwanda. Let me be precise. That let's not have academic doctors and clinical doctors. Let's have a doctor who is able to do academic work and clinical work. So they use the hospital as a teaching site. Let's transform our hospitals as classrooms, as teaching areas. Because otherwise, at the end of the day, the people you are teaching, they will be spending most of their time in the hospitals. There's no need to go and sit and compete the limited space at the university with other faculties if they can make hospitals the teaching site for university. And at the end, who benefits the most? The community, the patients. So that was one example of disconnection in our practice. There's no way you will be a good doctor if you're not seeing patients. There's no way you will be a good doctor if you're not learning, teaching, reading, using your data while seeing patients to improve academics. That should be applied elsewhere. We should avoid to have academics, clinicians separated. Once you start to see that happening, expect problems, expect that the Ministry of Health will not be connected to the Ministry of Education. And at the end of the day, we all connect to the cabinet. We are one team. And the president will not ask me, what about education, health education alone? The Minister of Education will be with me, explaining how we are improving medical education. It's not an issue of Minister of Education or an issue of Minister of Health. So we are all contributing to one thing. That is one thing we haven't done best. Every department on fields has the tendency of bringing it in one corner or the other corner. So we should all be in the same team, same place. Clinical academics should be one. It must be one. Is it happening everywhere? You will tell us. You will tell us. And sometimes when you don't create policies and guidelines to address this from the top, to become impossible to change, to become a new culture that will stay for generations and generations. We've seen this even in developed countries. And we are seeing it on this continent. While we build and create new things, we must learn from those kind of practices that were not good, but still happening. We should have the courage to disrupt it. What Phil Cotton was doing was actually these kind of examples. How do we disrupt things, even if we're born and they're there and we saw it? How do we have the courage to disrupt it? So that is the first thing I want to bring to this discussion, that even if we saw it, even if it's the way it's structured, we should have the courage to change it. Because if we don't, then our children will inherit this, and maybe they will not change it, then their grandchildren will, and so on and so forth. The second example is about the way or the how we teach. I asked young students recently in medical school how they are learning, how they are reading, things have not changed that much. The medical school we attended, most of the doctors here attend the same medical school. The same size, same classrooms, same library, same tree in front of the faculty. Everything remained the same. In Huye, the medical school is still the same. For me, it's 20 years ago. For others, probably 30 years ago or 40 years ago. Nothing has changed. Same thing. Surprisingly, even the way people are teaching, it did not change that much. Old PowerPoint slides, books or no books. A professor will come and read and teach and leave with some homeworks and go. Slight change, maybe you can search faster, make PowerPoints faster, not the projectors. Remember the plastic projectors. A few things changed, but we can change more, we can change even faster. I don't even think we need to send 300 or 500 young people to sit in Huye or in Butaro or in Kigali to sit for 12 months just reading biochemistry, biophysics, basic anatomy. These are the things that we have with our phones, with our computers. These are the things maybe these young people can read at home. With the internet penetration, with access, maybe you don't need to send everyone to sit there, spend a whole year just waiting someone to drive from Kigali to go and start introduction on biophysics, introduction on anatomy or physics. Maybe you can learn better. Maybe you can access a professor sitting in Barcelona or in Boston or in Paris, teaching our young people at home on their villages without spending a lot of money. Does this change the quality of education, or it improves even the quality of education? Because if you see the most time these students spend in those universities, it's all about logistics, cafeteria, eating, coming back. Maybe they need half of that time together, another half reading from the distance. Maybe this artificial intelligence, the AI algorithms can help even to summarize and teach better. This is another area I think we need to be humble enough and accept that the world is changing and we must adapt and change, even if we don't agree 100%, at least agree that there are new ways of doing things. In academia, probably is an area where change takes time, and is going to be in the resolution of this meeting, hopefully. And we are going to say, let's wait for the next academic senate in the next 6 months to discuss this and to review it, or next year. Again, that is another level of bureaucracy that we need to change. And if something has to change today, why do we push it to a Senate academic meeting of next year. That's another way, another challenge to address, to embrace. But otherwise, coming as deans, as partners to a meeting that will result to the same practices will be good for coming together. But what we need now is change. That's what I heard from previous speakers. We need change, we need a big change, because the needs are there. The needs are there, the diseases are changing, but the way we address or design our teaching programs is probably not connected exactly to what is out there. Last week I went to Northern Province for an outreach program, and we visited a hospital called Ngarama Hospital. Sorry, Gatonde, next to Ngarama. They are close to each other. We spoke to the community, asked, what are the main reason you came here? There were so many that came for military medical outreach programs that we were conducting together. And they said, actually, more than half, they were there for dental problems, for oral diseases. Then we discussed with the people at the University of Rwanda and other faculty who attended the same event. Do we have the same design of our education program addressed to the needs in the community? The answer was no. We don't have a focus on dental or oral disease program or tracks of education. Yet this is the main problem we have in the community. Actually, it's very rare to have a dentist or a dental therapist in our hospitals and our health facilities. On the other side, you have maybe faculties more into, I will use other examples without any target, maybe political science, history, gender, rural management, or water. These are important, but these communities need dental care, prevention of dental problems, dental care, than other priorities that we are putting forward, maybe because it's easy to teach, maybe because it's convenient for the universities, for academia to establish, it's faster. So if we have to solve the problems in the community, let's start with the community and ask what are the issues we have, how we go back and design solutions. In medical education, it's even urgent. If you had more road accidents and you don't have importance in training of neurosurgery in surgical fields, you're not addressing the problems. If you have maternal problems, maternal mortality, C-section challenges, you're not training that, you're not addressing the real problems. So before we create new faculty or fellowships or residence programs, let's go back and say, what are the most important, the most needed fields of this area that we're going to address in education, in research? Then we'll help implementation to happen. How does the Ministry of Education and Health brings all these actors together to design these programs? If you're not having that conversation, at least read, use data, and say at Senate, before we approve any new program or training, let's look at the statistics. Do we need to start residence for pediatrics or residence program for surgery? Within surgery, which one do we need to give high importance and why? Is it informed by evidence or not? What about the next 10 years? With technology, the role of AI, Is it going to solve the challenges we have in imaging, in pathology? Or AI has a limitation in some fields. They are the ones we're going to design differently. Some areas will be extensively supported by technology, by AI, like pediatrics, like town medicine, like maybe other areas not. Like hands-on, you need to be there. AI is going to help to do it better, like the telesurgery, robotic surgery. Some areas, maybe AI is going to take 9% of the burden of the work, like imaging. We're seeing it happening. How do we embrace it without pushing it back? Because the more we push it back, it's going to come back with more speed. Actually, you can't resist it to happen. The young people are already pushing it. Let's accept it, integrate it, embrace it, facilitate it. Last point is on research. Research must be transformed, must change as well. Research should not be just with the aim of publication. Research should be there to solve problems, should be there to train people on how to think, how to address issues in the communities. Research should not be there just to promote ourselves within universities. If research is not ending up by changing the lives of the people who don't expect, even who doesn't know how research is conducted, then that research is useless. And the money spent on those kind of research is the money lost. So changing research, make it a tool for solutions, a tool for education, a tool for thinking and teaching, should be the research we support. Research should not start when you're already a professor or an associate professor. It should start when you're a student, at the early years of education, so that you start thinking and even trying and testing with that energy. Because the more you grow, the more you think differently and even sometimes limit yourself into risks. And research is about taking some risks, calculated risks, sometimes crazy questions that will become a new standard in the future. So young people are better at that than those who are already achieved a lot in their career. So let's change research, let's transform it. Especially on this continent, there's a lot of questions that are not answered. It should be done by the people who are facing those problems. This morning I was listening one radio talking about a conference in South Africa. Some doctors were giving feedback about researchers who are flying in and collect data and go back. The conference about genomics, human genome in particular. And there are a lot of complaints about senior researchers just flying to collect information and go use the data to design new tools, new medicine, but nothing is left in the community. That should not be accepted. There should be also equity in the research. There should be respect to the communities where this data is collected. And if you collect data and you leave the community in the same problems that they had before you go back to collect the data, then you're just stealing, and that can't last longer. So that also must change. It must change from the way we conduct research. It should be for capacity building, for solution making, also transforming these people's lives. It could be small, it could be just small. Telling people your water is not clean, there's heavy metals in this water, it has to be addressed. To me, that is much better than a clinical trial, heavy new drugs that you'll never get the drug landing in that community. So that is another reflection that we need to bring in this type of conferences and meetings. Let me conclude by saying these are just reflections from what you said that I believe and strongly support that if we continue to work together through the consortiums, the universities, working together, not competing to each other, that we train young people who are going to solve problems, not just their own titles and affiliations. That is the reason why we should always be coming together as researchers, deans, policymakers, students, and also community representatives. Can it be achieved? 100% yes. We are even better positioned to achieve it with the power of technology, with the tools we have. We can even catch up with the legacy that we accumulated, especially on this continent. We can have more people trained, and training more doesn't mean you lose the quality. So you can even train less with low quality. Imagine that disaster. And imagine that opportunity to train more with the highest standard. And this is what we are aiming for. And that is what we've started to do in Rwanda with the support of several partners, universities, to form what we call 4x4 strategy. It means we are quadrupling the numbers of the healthcare workers we have, especially in the medical field. 4 times, because that's the minimum. All African countries, almost all African countries are below the minimum. Below the minimum. We are not even at baseline. So at least 4 times we reach the minimum, then we can start to run faster without concern about our health system at risk to collapse because there are too many patients and no doctors. So uplifting the quality, the quantity together is possible, especially when you add technology, you add partnerships, and you spend less. We just need one thing: the courage to do it. And I can see that there is courage in this room. There is empathy. There is commitment. There's always questions that maybe what Sabin is talking about is not possible. Or he's just dreaming. But we've seen from the history that when you want to transform something, there is always a big number of people who say it's impossible. Always. When everyone comes and say, yeah, let's do it, and we can do it, most of the time that objective, that goal, is too small and too easy to understand by everyone. When it's too big and too transformational, there's always a big number who say no. But there's a small number that will always say yes. Let's stick on it. Let's obsess it. And let's do it. And those are the people in the history who have changed, who have created these new standards we are living in. And we need those few people who believe that we need to train more people in medical education, train them well with the highest standards, and embrace technology as fast as possible, and obsess it and achieve it until we come back here and say, we said it in 2025, now we are back and it has been achieved. So, ladies and gentlemen, thank you so much for the opportunity, and I believe that we are going to achieve it. So it's my honor and pleasure to declare the conference open officially. Welcome to Rwanda. Welcome to medical education. Thank you.
Developing next-generation medicines requires next-generation scientists. In partnership with the University of Basel, we invite talented young scientists and clinicians from developing countries across Africa, Asia, and Latin America to our Basel campus for a 3-month research internship. Using state-of-the-art techniques and equipment, the interns expand their already advanced skills and knowledge in partnership with Novartis scientist mentors and each other. Interns work on projects designed to help them apply their expertise for maximum impact in their local communities. In addition to training sessions on drug discovery and development with input from Novartis scientists, they also take part in an intensive applied communications and leadership skills curriculum. Past participants have contributed to peer-reviewed publications and presented at international conferences. By facilitating open collaboration with individuals and institutions around the world, we seek to advance local healthcare infrastructures and to create an international network of scientific and clinical leaders. Next generation scientists, building a better future.